So this picture is also important, ladies and gentlemen. It's just showing you guys setup for the placement of dental sealants. We have our protective eyewear, we have our curing light, we have our tray basically that has our edge, our articulating paper, cotton rolls where necessary, our mirrors, our probes, our tweezers, and so on and so forth. But I think it's always important that you guys know what a tray for a specific procedure sort of has to look like. With dental sealants, we don't require as much equipment in terms of on our tray, but then just familiarize yourselves with that as well. So guys, here your slides basically show you step by step the procedure that we will perform in placing dental sealants. Like we had mentioned before, you're going to isolate and dry the tooth. So you have to actually technically first clean the tooth, either with a pumice and a pumice brush, or making use of a 3-in-1 syringe and then drying the tooth afterwards. That's what other dentists also do. By isolating the tooth, in this instance, they're making use of a rubber dam. Other dentists then also make use of just cotton rolls to isolate that particular field. And then from there on, we etch the enamel with our 37% phosphoric acid. Normally etching, we'll have to wait for this etching to occur with 20 minutes or for 20 minutes or 20 seconds or so, apologies. And then from there, we're going to clean it out and thoroughly dry the etched surface. As you guys can see on the picture, after actually drying the enamel, the tooth will have this really chalky white appearance. Okay, that's a really good indicator that we have etched appropriately. Okay, so on the etched surface, the sealant is placed and then we cure the enamel. But obviously before curing, we're going to make sure that we don't have any voids. Our sealant does not appear to be too high, and that the material is not placed or did not overflow to the adjacent teeth. And once we are satisfied with that, then we can cure the enamel. Normally curing takes about 40 seconds. That should suffice, ladies and gentlemen. Then once we are done placing the sealant, we then evaluate it. Like I said, is it not too high? Do not have any voids or air bubbles? Do not have any margins that could possibly cause micro leakages? Obviously, we'll then assess with our probe, obviously, that we do not have any of those signs. So once we are then happy, in some instances, then you will then polish your sealant and then go on to another tooth. So that's basically essentially what happens with sealant placement. It's not an invasive procedure. Sometimes can be time consuming, but not necessarily. But I think very simple and very straightforward. From there, ladies and gentlemen, we will be discussing baby bottle syndrome. This is such a problem in South Africa. Oh my word. Like, I don't even think a week passes by where you will not encounter such a child in your practices that you'll be working at. Very, very important. Yes, so basically with baby bottle syndrome, it's just severe childhood caries where a patient or our infants have 2 or more carious teeth as a result of a habit. In this instance, being obviously that the child there's like prolonged use of baby bottles, or even the fluids that are in the baby bottles contain so much of sugar. So normally then such a mother or such parents, even finances are an issue, where these teeth can also be so badly decayed that the child will present with periapical abscesses that we guys will have to treat. It will result in premature or early loss of primary teeth. Like I said, will cause the child spacing issues when they grow up, because now the teeth that we would have relied on being their primary teeth to actually guide the permanent ones into the oral cavity are not there anymore. These kids have orthodontic problems. They have skewed teeth. They have spacing issues. They have deficiencies. They have rotated teeth. So it's just quite an issue to treat, actually, and almost in all instances will result in serial extraction. And that being said, multiple or extraction of multiple teeth because they're so severely decayed. And sometimes the children themselves are not cooperative by the time they get to your practices. Like I said, you will find instances where there's multiple teeth that are rotten or decayed, and others have periapical abscesses. Sometimes the teeth then become mobile as a result, or you'll find that the only roots remain. That's how badly decayed the teeth are. Yeah, so it's quite a problem. So this basically, the baby bottle syndrome starts with the pregnant mom. And that being said, if you get a pregnant lady into a dental chair, at that particular phase, you really try and just educate this pregnant mom on how to feed the child, because others get weaned off of breast milk quite early on, once they're born or after they're born. So we're basically just going to encourage the pregnant mom to not add sugar to drinks. This is very important. Or just not make use of drinks that are high in sugar, such as your 100% fruit juices. Like, they're actually quite shocked most of the time to actually realize, ladies and gentlemen, that a glass of 100% fruit juice actually has about 6 tablespoons of sugar. So it's actually, they actually get quite shocked. So even if they actually use 100% fruit juices, you will encourage the mother that even for kids that are off bottles but are just now drinking juices and stuff, that only half of the cup has to have fruit juice. Then from there, they can just add water and the taste will still be the same. I cannot emphasize how much sugar these 100% fruit juices have. So we tell we tell mommy not to add sugar to drinks. So even if they're making teas or rooibos in those baby bottles, to not add sugar, or at the most half of a teaspoon. And then from there, we try and encourage them to not let baby sleep with the bottle, because that's how we get to this stage, ladies and gentlemen. And you can see how scary the baby bottle syndrome, or a child with a baby bottle syndrome, looks like, because this syndrome essentially causes pain and discomfort for the baby, and sometimes it's so painful having to extract the child, because not all of them can afford sedation or to get their teeth removed in theater, which costs thousands of rands. We have to do it in chair, so the child is like scarred for life. They have a bad perception or ill-conceived feelings for dentists and dental practices. So this will not be a cooperative or a regular patient going forward, which is what we're trying to achieve with pediatric dentistry, is that the patient get into a routine or good oral habits and dental habits at home, but also encourage them to actually come regularly for their dental checkups twice a year. So such a child, after having multiple extractions, will not want to come, and now we cannot make sure that they are developing properly through their developmental stages. So it's actually like, yeah, it's a very hectic problem. From there, ladies and gentlemen, pediatric dentistry also involves making use of early orthodontics, my favorite. So here, this is our child who's been coming every 6 months or once a year, depending on patient factors as well. So in our toddlers, early mixed all the way up to the eruption of our permanent second molars, we will be seeing, or if we identify problems or even habits that we need to intercept, that's when we'll make use of appliances associated with early orthodontics, known as preventative as well as interceptive orthodontics. So this would include making use of space maintainers. So these are kids who teeth were extracted prematurely. Primary teeth were extracted prematurely. So now we need to save that space, because if we do not save that space, we'll find mesial drifting of our teeth. So this could possibly cause rotations or even impactions of teeth, of permanent teeth going forward, or even space discrepancies in the mouth. So now teeth are not erupting properly. Now the child has now skewed teeth because the space was not maintained. So here in this picture, we have an example of abandoned loop where a D was prematurely extracted. So we're trying to save that space so that the premolars can erupt when the time comes. And then for oral habits, we have our patients that thrust their tongues, and then even most commonly our thumb suckers. So normally with thumb suckers, ladies and gentlemen, I'd say from ages 2 to 4, it's still sort of acceptable. If we find then our toddler patients from the age of 5 still have a thumb sucking habit, we'll then have to place an appliance such as a palatal crib to actually stop the patient from thumb sucking, because one, thumb suckers then have that habit that causes anterior open bites, causes malocclusions, and even the child in J it tends to be more socially isolated because they're just fixed to their habit. So one, we try and identify. So once the child is in chair, we're actually trying to find out, like, why is this child still thumb sucking before it becomes pathological, né? So in that instance, then we need to find any factors. Is the child being bullied at school? Are there problems at home that's causing this child to still be having this habit? Sometimes you find patients, especially mothers, are too lazy to break the habit, or they find that the child is not cooperating in breaking the habit. That's when we'll actually place this palatal crib, as I'd mentioned before, to actually help mommy and assist the parents in actually breaking the habit. So that's when we'll then make use of a palatal crib, as you guys can see there. Another thing we'll commonly find in pediatric practices are emergency procedures. So this would be instances where the kids were playing and then one fell and then someone's tooth came out and then people are crying, everyone's hysterical. Now mommy then brings the child to the practice asking for assistance, né? Or sometimes they actually, at the scene of the incident, very rarely they'll actually call you as the dentist or the dental assistant or whoever's at reception that, hey, my child's tooth fell out, or they're at a soccer game. What can we do? We still have the tooth in front of us. It fell, they picked it up. What can we do to then get assistance in this regard? So then you'll have to then inform mommy or daddy or the guardian to actually rinse to get rid of any grass or gravel or any debris where the tooth fell out. So they'll have to then pick the tooth up and actually rinse it of such substances or debris. And then from there, the tooth, or you encourage whoever's over the phone to then ensure that the tooth does not dry out by actually placing the tooth in milk or wrapping it with a damp cloth, né? And also motivate them or encourage them to actually get to the practice as quickly as humanly possible. And then once they've arrived, you actually put the child in chair, give local anesthesia where appropriate, and then place the tooth back into the socket in an anatomically correct position, né? Normally such teeth we monitor for a couple of weeks. We actually even in certain instances place a splint behind the tooth just to help the tooth actually stay in the socket, allow for bone remodeling to happen around the root of that tooth, and then from there we'll just take it from there. So if such a child or a patient comes for an emergency appointment at the dentist within a space of 30 minutes, we have a 90% success rate of actually getting that tooth in there and making it stable and not mobile over a couple of weeks, né? And then from there, if maybe you have a child who comes to the practice and the child engages in contact sports such as soccer and rugby and netball and sports to that effect, we will then encourage such a parent to actually buy a mouth guard for the patient. Prefabricated mouth guards, ladies and gentlemen, they're not that how can I say, successful because they do not conform to the patient's oral cavity and dental needs. So in such a case, we would then take alginate impressions of the patient's oral cavity, maxilla and mandible, send it to the lab and actually make customized trays or mouth guards that are specific to our patient. Okay, so that's essentially what happens in an emergency appointment. So once we as the weeks go by and we're satisfied that this tooth is stable, it's not mobile, it is anatomically correct, that's when then it's the dentist's responsibility to take periapical x-rays, assess the vitality of the tooth, and sometimes we may even have to do like root canal therapy on that tooth just to try and increase its survival rate. So essentially, that's what happens in an emergency procedure.